All right, let's dive into vascular disorders of the hand. We're going to focus on what you really need to know for your FRCS plastic surgery exams. You've sent us a ton of material, and it can be overwhelming, so we'll distill it down to the must-know, high-yield points.
Yeah, think of it like a super focused revision section, hitting the key points on how these problems present, how you diagnose them, and the core treatment principles. Ready to jump in?
Absolutely, let's do it. So first things first, when we're talking about vascular disorders of the hand, they tend to fall into three main buckets, right? You
Yeah,
got your trauma, ischemia, and tumors.
right on.
Trauma can be pretty straightforward, like a direct injury, or it can have those delayed consequences leading to things like aneurysms down the line. Ischemia, on the other hand, that can be sudden, like when an embolus lodges in a vessel. Or it can be a more chronic issue like Raynaud's phenomenon.
Yeah, and tumors can be there from birth, like you see with some arteriovenous malformations, or they can develop later on, like the classic glomus tumor.
Now, let's talk about what you need to pay attention to when you're taking a history from a patient with a possible vascular issue in their hand.
All right, so history is everything, right? You really want to dig into things like cold intolerance. Does the hand feel cold all the time, or just in certain situations? And then numbness or tingling, those are red flags too, especially in the fingers. And don't forget about hand cramping, particularly with fine motor activities.
Yeah, that's important.
Ask about any color changes they've noticed in their hand.
Hmm.
And it's a good idea to ask about past fingertip wounds too, even if they seem minor. They could be a clue. Oh, and never forget about tobacco use. Always ask about that.
Right. Sometimes what looks like a simple finger infection or a nail problem can have a deeper vascular cause.
Exactly.
Now, moving on to the physical exam, a really thorough vascular assessment is super important. You want to check out the skin color, temperature, and see how the skin bounces back. It's turgor, capillary refill, of course, that's a classic,
Yeah.
and palpate those peripheral pulses. If you need to, grab a Doppler to make sure you're getting a good signal. While you're at it, feel for any masses and listen carefully for any bruits or thrills. They can be subtle.
Right.
Don't forget Allen's test. It's a must-do to check the patency of the radial and ulnar arteries.
Absolutely.
You'll want to assess the range of motion of the hand and wrist, too. See if there are any limitations there. And take a look at the overall muscle bulk, making sure there's no obvious wasting.
All right, so let's say you've done your history and physical exam. What about imaging? Where does that fit in?
Well, the Doppler ultrasound that we mentioned, that's a great first-line tool. It's non-invasive, easy to do, and can give you a lot of information about blood flow. But if you need more anatomical detail, especially to see how things are positioned in relation to each other, a CT angiogram or CTA, that's your go-to.
Yeah, the CTA is really powerful for getting that clear spatial picture. You can also use MR angiography, MRA, but generally speaking, the CTA gives you better detail when it comes to those spatial relationships.
Let's talk trauma. Specifically, traumatic arterial injuries. What are the red flags that tell you to suspect something might be up?
Okay, so you're examining a patient with a hand injury. Maybe it's a deep laceration or a crush injury, something like that. There are 7 key findings that should make you think, hold on, could there be an arterial injury here?
7. Okay, I'm ready.
First, is the pulse diminished or absent? That's a big one.
Yeah, makes sense.
Second, did they have a lot of bleeding initially? Bleeding that just wouldn't stop, that seemed like it was coming from an artery.
Okay, so the nature of the bleeding, that's important.
Number 3, is there a hematoma? A big one or one that seems to be growing? That's not a good sign.
Right, definitely a sign of trouble. What's number 4?
Fourth, did they lose a lot of blood? Enough to make their blood pressure drop. That suggests a significant vascular injury.
Okay, major hemorrhage. Got it. What else?
Fifth, can you hear a bruit, that whooshing sound near the injury? That's a sign of turbulent blood flow and could mean there's damage to an artery.
I'll be listening for that for sure.
Sixth, is there a nerve injury in the same area? That can sometimes go hand in hand with arterial damage. And lastly, number 7, is the wound close to a major artery? Even if you don't see other signs, proximity to a named artery should raise your suspicion.
So those are the 7 key findings to look out for. Now, what if those physical findings aren't totally clear-cut, but you're still worried because the wound is near an artery? What then?
Well, in that case, angiography is the next step. It's the gold standard for visualizing the arteries, and will tell you for sure if there's an injury. Another situation where you'd go for angiography is if you notice a big difference in the Doppler signals when you compare the injured hand to the other hand.
So you're basically looking for asymmetry in the blood flow. Got it.
Exactly.
Hmm.
Now, there are times when you might consider going straight to surgical exploration, especially if the injury is distal to the mid-forearm and the findings are unclear. But angiography is usually the way to go.
Now, something we see a lot of is radial artery cannulation. It's generally considered a pretty safe procedure, but what are the potential complications we need to be aware of?
Yeah, radial artery cannulation is super common. And for the most part, it is safe. But like any procedure, there are risks. The most frequent ones you'll see are temporary thromboembolism, where a clot forms and blocks the artery for a bit, and hematoma formation, bleeding around the puncture site.
Okay, so those are the common ones. Anything more serious that we need to know about?
Thankfully, permanent ischemic damage and pseudoaneurysm formation are rare. But they can happen, so it's important to keep them in mind.
All right, good to know. So let's say we've diagnosed a traumatic arterial injury. How do we approach treatment?
Well, the treatment really depends on the specifics of the injury. If only one of the forearm vessels is damaged and there's no nerve injury involved, you can often get away with just ligating the vessel, tying it off.
Yeah, simple ligation.
Right. And typically, this doesn't cause any major problems. You might see some minor changes in the hand's blood flow, but patients usually don't have any symptoms. They won't be complaining of cold sensitivity or anything like that.
Okay, so that's if there's no nerve injury. What if there is a nerve injury along with the single forearm vessel injury? Does that change things?
It definitely can, especially if it's the median nerve that's affected. In those cases, repairing the artery is usually the best course of action.
Interesting. Now, I would think that if you repair the artery, it would help the nerve recover better. Is that the case?
That's a good question. And you would think so, right? But the evidence isn't crystal clear on that. The arterial repair itself doesn't seem to directly agree to how the nerve heals.
Okay.
However, there is some evidence suggesting that when you have an ulnar nerve injury, it tends to recover better if the associated artery is repaired too. So it's a bit nuanced.
Yeah, so it seems like it's more beneficial for the ulnar nerve than the median nerve.
That's what the research seems to indicate, yeah.
Yeah. Okay, so single vessel injury, we've covered that. What about if both the radial and ulnar arteries are injured? What's the game plan then?
Well, in that scenario, your goal is to repair at least one of them. And ideally, it's the ulnar artery that you want to fix. You can then ligate the damaged ends of the other artery.
So prioritize the ulnar artery repair if you can.
Got it. What about injuries to the superficial volar arch? How do you manage those?
Okay, so with the superficial volar arch, if you see good, brisk bleeding from both cut ends, ligation is usually all you need. But if the flow from one end is sluggish or there's no flow at all, then you'll want to go ahead and repair it. Remember, if you can restore the normal anatomy safely, that's always a win.
Makes sense. So we've covered traumatic arterial injuries pretty extensively. Let's shift gears and talk about aneurysms in the upper extremity. What causes those? You got it. Well, in the upper extremity, trauma is the #1 culprit when it comes to aneurysms. Atherosclerotic aneurysms, the kind you might see in other parts of the body, they're actually pretty rare in the arm and hand. And then there are mycotic aneurysms, which are usually linked to things like non-sterile injections or septic emboli.
So those are more infection related.
Right, and you'll find that these aneurysms tend to pop up more frequently in the wrists and the digital arteries.
Okay, so location matters. Now, you mentioned true aneurysms and false aneurysms. Can you break down that difference for us? Because I know it comes up a lot on exams.
Absolutely, it's a key distinction. So true aneurysms, they involve all 3 layers of the artery wall, and they usually develop because the wall itself has become weak, either from trauma or some underlying disease process.
Got it.
Trauma is the most common cause, like we talked about. And in the hand, repetitive blunt trauma to the palm can lead to something called hypothenar hammer syndrome. That's a classic.
Yeah, I've heard of that one.
It specifically affects the ulnar artery as it passes through Guyon's canal. All that pounding basically damages the artery and can eventually cause a true aneurysm or the thrombosis.
So it's like wear and tear on the artery. Interesting. What about false aneurysms? How do those form?
So false aneurysms or pseudoaneurysms, they're actually more common than true aneurysms in the hand. They happen when an artery gets a hole poked in it, a perforation, and blood leaks out into the surrounding tissues, forming a hematoma.
Like a contained bleed.
Exactly. And over time, this hematoma starts to turn into scar tissue. The key thing is, a false aneurysm doesn't involve all 3 layers of the artery wall, unlike a true aneurysm.
So it's kind of a contained blood collection that's walled off by scar tissue.
That's a good way to put it. And a helpful way to remember the difference is that true aneurysms often have a fusiform shape, kind of like a spindle, while false aneurysms tend to be saccular, like a little pouch.
That's a good visual, thanks. Now, how do you diagnose an aneurysm in the hand?
Well, a lot of times you'll be able to feel it. It'll present as a mass that you can palpate, and it'll have this pulsatile quality to it. It might also be tender or painful.
So a pulsatile mass, that's a pretty big clue.
Right. Now, if the aneurysm is buried deep or it's small, you might not be able to feel it, but you might see signs of digital ischemia, like pain and pallor in the fingers. That's because little clots can break off from the aneurysm and block the smaller arteries downstream. And of course, you'll want to do Allen's test to assess the overall blood flow.
Makes sense. What about imaging? Is that usually needed?
Imaging can be helpful, but an arteriogram isn't always necessary to make the diagnosis.
Okay, so clinical suspicion is high on the list. Now let's talk about treatment. What are the options?
When it comes to treatment, surgery is usually the way to go. The typical approach is to resect the aneurysm, remove it completely, and then you have a couple options for restoring blood flow. You can either repair the artery directly, or if the damage is too extensive, you can use a vein graft.
So resection and then either primary repair or a graft.
Exactly. Now, there are situations where you might just ligate the aneurysm after resecting it. This is more likely to be an option if it's an aneurysm of the arterial arch and you're confident there's good collateral circulation.
So that's an exception. Interesting. Okay, before we move on from trauma, I want to touch on ulnar artery thrombosis and other local artery thrombosis. What can you tell us about those?
Sure. So ulnar artery thrombosis in Guyon's canal, that's often a result of direct trauma to the area.
Okay, so similar mechanism to hypothene or Hammer syndrome.
Yeah, kind of. Patients with this will often complain of pain that's worse at night or when they're using their hand. They might also have cold intolerance.
Those sound familiar.
Right, and on exam, you'll usually find tenderness right over the spot where the thrombosis is. As things progress, you might see dependent rubor, which is redness that appears when the hand is hanging down, or even ulcers, especially on the ring and little fingers.
Okay, so that's a sign of chronic ischemia.
Exactly. And you can also get some weird symptoms from irritation of the sympathetic nerve fibers that run along the ulnar digital nerves.
So that explains the pain and the color changes.
Yeah.
How do you confirm the diagnosis?
Well, Allen's test is usually pretty reliable for picking up ulnar artery thrombosis. And an arteriogram can be helpful to map out the extent of the blockage and plan your treatment.
All right, so let's say you've diagnosed it. What's the treatment approach?
The standard treatment is to ligate the artery above and below the blockage and then resect the thrombosed segment. Basically, you're just removing the clotted part.
So you're taking out the bad section.
Exactly. Now, you only need to do a reconstruction, like with a vein graft, if the blood flow from the radial artery isn't enough to compensate.
Okay, so you're basically checking if the hand has adequate blood supply from other sources. All right, we've spent a good amount of time on trauma. Let's switch gears and talk about ischemia. And let's start with emboli. You mentioned that emboli to the arm and hand aren't as common as in other parts of the body. Why is that?
Well, they are less common. They only account for about 15% of all embolic events. And the main reason is anatomy. The arteries that supply the arm and hand are branching off the aorta differently than the arteries that go to the legs, for example.
So it's less likely for an embolus to take that path.
Yeah, that's part of it. But when we do see emboli in the upper extremity, where are they coming from? Well, the most common source is the heart. Conditions like atrial fibrillation or recent myocardial infarction, those can throw clots that can travel and lodge in the arm or hand.
Okay, so those are the big ones. Are there other sources we need to consider?
Oh, absolutely. You can have emboli coming from things like thoracic outlet syndrome, where the vessels get compressed, or from atherosclerotic plaques, those fatty buildups in the arteries. Aneurysms of the subclavian or axillary artery can also be a source.
So any source of a clot, basically.
Pretty much. And don't forget about some of those less common arterial diseases like Takayasu's arteritis or giant cell arteritis. Those can cause problems too. Oh, and sometimes you'll see emboli originating from vascular grafts, either because of a mechanical problem with the graft itself or because a clot has formed within the graft.
So it can be the graft itself or the underlying reason for the graft.
Right. And then, of course, you have penetrating trauma, which can obviously introduce clots into the bloodstream. And even things like catheter-related procedures, or in kids, supracondylar fractures of the humerus, those can all lead to emboli.
Wow, so the list is pretty extensive. Now, how does an embolus to the hand typically present?
Well, if it's a big embolus, a macroembolus, usually coming from the heart, It'll cause a sudden blockage of a major artery.
And that's a dramatic presentation, right?
It is. You get the classic 5 PS, pain, pallor, pulselessness, paresthesia, and poikilothermia. That last one just means the extremity is cold.
Yeah, that's a surgical emergency. What about if the emboli are smaller?
Well, smaller emboli, like those that break off from atherosclerotic plaques or the thrombi in an artery, they can travel further down into the smaller vessels of the hand. And that can actually cause symptoms that mimic Raynaud's phenomenon.
Okay, so it's a different presentation altogether.
It is.
Right.
Now, how do we diagnose an embolus? Well, arteriography is the gold standard, and it's important to do a thorough arteriogram, usually accessing through the groin, so you can visualize the entire subclavian artery and all the branches that supply the arm and hand.
So you need to see the whole picture.
Absolutely.
Mm.
And treatment. Well, that needs to be aggressive and it needs to be prompt. We don't want to waste any time. The preferred approach, in many cases, is to do a surgical embolectomy. That means making an incision into the affected artery, usually a bit more proximally, and using a Fogarty catheter to remove the clot.
So you're going in and physically removing the blockage.
Right. Now, there's also a technique called percutaneous intra-arterial thrombolysis. This involves using medications that dissolve clots, and they're delivered directly into the blocked artery.
So it's like a targeted clot-busting therapy.
Exactly. And sometimes this is done in combination with a vasodilator to help open up those blood vessels because the arteries in the upper extremity can be prone to spasm and can be really effective in the right cases.
Okay, so those are the main treatment options for dealing with the clot itself. What about managing the pain? Because I imagine these emboli can be pretty painful.
Oh, you bet. And sometimes the pain is really severe and doesn't respond to regular pain meds. In those situations, a stellate ganglion block can provide some temporary relief.
That's a nerve block.
It is. It targets the stellate ganglion, which is a cluster of nerves in the neck that helps regulate blood flow and sensation in the arm and hand. Now, if the pain is more chronic and it's due to those tiny clots blocking the very small vessels, you might consider a cervicodorsal sympathectomy. That's a surgical procedure that disrupts those sympathetic nerves more permanently. It can be a good option for long-term pain management in some cases.
Okay, so you have options for both acute and chronic pain management. That's good to know. Now, let's go back to the different causes of emboli. You mentioned that the treatment approach can vary depending on the source of the clot. Can you elaborate on that?
Sure. So if the emboli are coming from the heart, you need to act fast. Intravenous heparin is started right away to prevent further clotting, and then you do a surgical embolectomy to remove the clot that's already there.
So heparin for immediate control and surgery to get rid of the existing clot.
Exactly. But here's the key. Patients who have heart-related emboli have a really high risk of recurrence. About a third of them will have another embolic event if you don't put them on long-term anticoagulation.
Wow, that's a significant risk. So long-term anticoagulation is critical.
It is. And the choice of medication and how long they need to be on it, that depends on the underlying cause. But it's absolutely essential to prevent those recurrent emboli. Now, when the embolus doesn't originate from the heart, like if it's related to trauma or something else, just doing a thrombectomy might not be enough. The success rate is much lower, around 20%, compared to that 95% success rate we see with cardiac emboli.
So why the difference?
Well, in these non-cardiac cases, you often have some underlying damage to the artery itself. Maybe there's a stenosis, a narrowing, or some disruption of the inner lining of the artery, the intima. And that can set the stage for more clotting. So you might need to do more than just remove the clot. You might have to repair the artery too, either by patching it, doing a resection and reanastomosis, or using a graft. And heparin is usually given before surgery, but long-term anticoagulation isn't typically necessary in these situations.
Okay, so you're addressing the underlying problem, not just the clot itself.
Precisely. Now let's touch on kids with supracondylar humeral fractures. These fractures can sometimes damage the brachial artery, which is the main artery supplying the forearm and hand, and that can lead to ischemia and even compartment syndrome, which is a surgical emergency.
Yeah, it's scary.
It is. So if a child has a supracondylar humeral fracture, you really need to be on high alert for vascular compromise. Doppler ultrasound is super helpful here. It's non-invasive and can give you a good idea of how the blood flow is in the arm. If the Doppler signals look abnormal after you reduce the fracture, meaning you've set the broken bone back in place, that's a sign that you need to explore the artery surgically.
So you're not messing around. Straight to surgery.
Yep. And in those cases, you'll usually need to repair the brachial artery. That involves removing any clot that's there and then fixing the damage to the artery itself.
Hmm.
Now, arteriography can be helpful in some cases to plan the surgery, but you don't always need it.
Okay, good to know. Now, what about emboli that are more proximal, like in the subclavian or axillary artery? How do you manage those?
Okay, so with subclavian or axillary emboli, the priorities are to identify and treat any underlying disease that might be causing the emboli, restore good blood flow to the arm, and remove any clot that's made its way further down the artery. Bypass grafts are often used in these cases to reroute the blood flow around the blockage.
So you're bypassing the problem area.
Right. And it's important to remember that if you encounter a patient with unexplained ischemia in the upper extremity, you should really consider doing a brachiocephalic arteriogram. That's an X-ray study that looks at the major arteries in the chest and neck, and it can help you find the source of the problem.
Okay, so it's a more comprehensive look at the vasculature.
Exactly. Now, if the emboli are related to inflammatory conditions like Takayasu's arteritis or giant cell arteritis, corticosteroids are usually the first-line treatment. They can help reduce the inflammation and improve blood flow.
So you're targeting the underlying inflammation.
Exactly. But if the ischemia is severe and chronic, you might need to do surgery, even with these conditions. Bypass grafts are again an option here. And when dealing with thrombosed vascular grafts, meaning a graft that's been put in place surgically is now clotted off, the first step is to start intravenous heparin right away. Then you'll need to do surgery to remove the clot and revise the graft if possible.
So that's a tricky situation.
It can be, and there are a lot of different configurations for these grafts depending on where the blockage is and what vessels are involved. The patency rate, meaning how long the graft stays open and functioning, tends to decrease with each revision.
So multiple revisions are not ideal.
Not really. But thankfully, we have some newer percutaneous techniques like angioplasty and stenting that can be used to try and improve the long-term patency of these revised grafts. So that's a good development.
All right, that's a lot of ground we've covered on emboli. Let's move on to Raynaud's phenomenon. Can you give us a refresher on what exactly that is?
You bet. So Raynaud's phenomenon, it's basically a condition where the small arteries in the extremities, usually the fingers and toes, they go into spasm, they constrict. And that causes a temporary reduction in blood flow.
Okay, so a vasospastic disorder.
Exactly. And this spasm is usually triggered by cold temperatures or stress.
So someone's hands might turn white or blue in the cold.
Right. Now, there are two main types of Raynaud's. There's Raynaud's disease, where the vasospasm occurs on its own without any other underlying health problems.
So that's primary Raynaud's.
Exactly. And then there's Raynaud's phenomenon, where the vasospasm is associated with another condition, like an autoimmune disorder.
So that's secondary Raynaud's. And you mentioned autoimmune disorders. What kind of disorders are we talking about?
Well, scleroderma is a big one. Almost everyone with scleroderma has Raynaud's phenomenon. Other autoimmune disorders like lupus, rheumatoid arthritis, Sjogren's syndrome, those can also be associated with Raynaud's. But if someone has had Raynaud's for more than 2 years and hasn't developed any signs of another illness, it's unlikely to be secondary to an autoimmune condition.
So if it's isolated for a long time, it's probably primary Raynaud's.
That's generally a safe assumption.
Okay, so now let's talk about the pathophysiology. What's actually happening in the blood vessels during a Raynaud's episode?
All right, so it starts with this intense vasospasm of the small arteries, those arterioles. And that causes the blood flow to decrease dramatically. That's what leads to the pallor, the whitening of the fingers. And sometimes they'll even turn blue, cyanotic, because the blood that's stuck there is losing its oxygen.
So white, then blue. What happens next?
Well, eventually, the spasm starts to let up, the vessels open back up, and blood comes rushing back in. And that's when you see the redness, the erythema.
So it's a 3-phase process. White, blue, then red.
You got it. And the key thing here is that these changes are reversible. The blood flow eventually returns to normal. That's what sets it apart from conditions like vasculitis or thrombosis, where the blood flow is disrupted more permanently.
Okay, that's an important distinction. So it's temporary, but I imagine it can still be pretty uncomfortable. Do patients with Raynaud's usually have other symptoms besides the color changes?
They can. They might experience numbness, tingling, or a burning sensation in the affected fingers. And it's important to note that while the fingers are the most common site, Raynaud's can also affect the toes, nose, ears, even the nipples. And the changes usually have this sharp line of demarcation, a clear border between the affected and unaffected areas.
So it's not a gradual change. It's pretty distinct.
Right. Now, ulceration and tissue loss, those are rare in primary Raynaud's, But they can happen in secondary Raynaud's, especially if the underlying condition is causing more severe vascular damage.
Okay, so the complications are more likely with secondary Raynaud's. Got it. Now, how common is Raynaud's and who gets it?
Well, primary Raynaud's, it's estimated to affect about 3 to 4% of the population in the United States. For secondary Raynaud's, the incidence really depends on the underlying disorder. Like I said, it's almost universal in scleroderma.
So if you have scleroderma, you're almost guaranteed to have Raynaud's.
Pretty much. And as for who gets it, primary Raynaud's doesn't seem to have any racial predilection. But secondary Raynaud's, that follows the patterns of the underlying diseases. As for age, primary Raynaud's typically shows up in the second or third decade of life, while secondary Raynaud's, the onset usually coincides with when the underlying disorder develops.
So young adults for primary, and it depends on the other condition for secondary. Okay, so let's say you're seeing a patient and you suspect Raynaud's. What are the key things you're looking for in their history?
All right, the history is super important for diagnosing Raynaud's. You want to ask about the classic symptoms: numbness, pain, and at least 2 distinct color changes that happen in response to cold or stress. That's key. It has to be at least 2 colors, and it has to happen multiple times.
Okay, so it's a pattern, not just a one-time thing.
Exactly. And if they have any other symptoms, that could be a clue that there's an underlying condition driving the Raynaud's. You also want to ask about their occupation, see if they're exposed to anything at work that could be a trigger. Things like vibration or certain chemicals can make Raynaud's worse. And it's worth asking about any history of frostbite or other injuries to the hands. Those can sometimes predispose to Raynaud's.
So occupation, exposures, past injuries, those are all important.
Got it. Now, what about lab tests? Are there any specific tests that help diagnose Raynaud's?
Well, there's no one test that definitively diagnoses Raynaud's, but you can do some lab tests to rule out other conditions and look for signs of an underlying disorder. So basic blood work like a CBC, kidney function tests, liver function tests, those are a good starting point. You might also check for inflammation markers, autoantibodies, things like that. But the history and physical exam, those are really the cornerstones of the diagnosis.
So the labs are more for ruling things out or looking for associated conditions. That's right. And what about imaging? Does that play a role in diagnosing Raynaud's?
Well, thermography and arteriography have been used in the past, but honestly, they don't really add much beyond what you can gather from a good clinical assessment. One thing to remember is that a lesion that's persistently cyanotic, meaning it's blue all the time, that's not Raynaud's. In Raynaud's, the color changes are temporary.
Exactly. So you've made the diagnosis of Raynaud's. Now what? How do you treat it?
Well, for primary Raynaud's, the mainstay of treatment is medication. Calcium channel blockers are usually the first choice. They help to relax the blood vessels and prevent those spasms. Nifedipine is a common one, but there are others like amlodipine and diltiazem.
Right. And the key with these medications is to start low and go slow. You want to find the lowest effective dose to minimize side effects.
So start low, titrate up slowly.
Got it. Are there other medications that are used for Raynaud's? Yeah, there are some other options that are being studied. ACE inhibitors, those blood pressure medications, they might be helpful. And prostaglandins, those are medications that can also dilate blood vessels. They're being explored too. But antiplatelet agents and anticoagulants,